Introduce the next speakers, speaking about optimal candidates for repeat focal therapy and outcomes, Dr. Tan.
I want to thank the organizer for the opportunity to talk about optimal candidates for repeat focal therapy. I have no disclosure. So I think to stratify this, essentially focal therapy, primary focal therapy, the sweet spot of this is patients with intermediate risk prostate cancer. Most people are offering focal therapy for that. So for the purpose of this talk, we are going to focus our attention on patients with, who fall into this category. Following focal therapy with low risk, intermediate, or high risk, they are risk stratified once again based on your pre-focal therapy risk stratification score to determine if they are going to be candidates for a repeat ablation. I want to highlight a few things. Remember, the NCCN guidelines, which most of us use in the US, specifically states that patients who have under 10 years of life expectancy, and depending on the risk stratification, under 5 years of life expectancy, that should really guide our management in terms of offering patients appropriate therapy. For example, if the patient falls into a very high-risk category and they have less than 5 years of life expectancy, the recommendation in that category is mainly supportive care or observation. So it's very important to go back to our guiding principles that at the end of the day, if they recur following first-line focal therapy, we want to make sure that we are following this to determine if they should even undergo a second ablation. But let's say you determine, all right, the patient's going to live more than 10 years. Let's think about what we can offer them. At the end of the day, it falls into the same principle as primary focal therapy. No evidence of metastatic disease on imaging study. Ideally, grade group 2 or 3, or maybe low volume grade group 4 in select patients. As we've spoken and discussed throughout the entire conference thus far, there is really no cutoff for the PSA, but the general rule of thumb is that you want to think twice about doing focal therapy in somebody with a PSA above 20. Ideally, you want to have a targetable lesion on MRI or ultrasound, and ideally a solitary lesion. We've spent the conference discussing energy modalities out there. For US practice, I guess the bulk of us are doing cryotherapy and HIFU and IRE if they're Medicare patients, because that's the only group of patients who they are reimbursable. And the question is always which modality to use. In general, posterior, I use HIFU. Anterior, I use cryo. Periureterally, it makes sense to use IRE, but even then, we don't have access to that because of billing in this country. So the other questions that becomes important when we determine whether, what we're going to do to salvage patients in this situation. Visibility. To me, the best outcome to determine success after focal therapy is whether it's visible on the ultrasound. If you see it on the ultrasound, you are going to be very comfortable treating it to whatever margin you desire. At NYU, we use a 10 millimeter margin because we've found in whole mount specimen that actually decreases the rate of recurrence. You want to question, is this an in-field failure or out-of-field failure? Is this on the contralateral side? Is it because of the margin failure, which is usually what in-field failures are? You want to know if there's calcification on the ultrasound, especially if you're thinking of doing a second HIFU. Because at the end of the day, that's going to dictate whether you're going to be successful. You want to know if you can visualize the prostate on the ultrasound. In certain instances, I've gotten second opinions where patients come in after getting treated elsewhere. They get a whole gland HIFU and they come in and you can barely see the prostate. If you can biopsy anything in the prostate, that's kudos to you. But it's very challenging in those situations. You get scar tissue, you barely can see anything on the ultrasound. You want to know how big is this lesion. You want to know the size of the lesion. So a lot of these are not hard cutoffs, but are important questions to determine if we can potentially do a second focal therapy on this. So what is the data out there pertaining to this? This is early data from Dr. Amberton's group at UCL. This was initially when they were doing very focal HIFU between 2004 to 2012, where they were not doing HEMIs and they were only going one pass with the Sonoblade device. 36% of these patients got retreatment. The median follow-up is relatively short, but what's important to know, what I wanted to highlight is that if you look at the urinary function, It got a little bit worse in terms of being pad-free after second HIFU. Obviously, this is in the earlier times when there was still a learning curve where HIFU was just initially getting popular in the UK. Sexual function-wise, interestingly, the erectile function was pretty similar. So Dr. Amberton's group subsequently published their more updated series where, by then they've done 800 plus patients. This is about 4 or 5 years old now. Not many of them has completed the questionnaire, but when you look at it, what I wanted to highlight is that immediately after HIFU, we do note a worsening erectile function. This is the same that we notice in cryoablation as well, but over the period of 1 or 2 years following that, the erection typically improve. When we look at the leak rate following Dr. Amberton's group at patients undergoing HIFU, you can see that the immediately after HIFU there was a 1% decline in terms of their leak-free rate, but subsequently that improved, probably with Kegel exercises and other activities. When you look at the pad-free rate, 97% of them were pad-free 2 to 3 years after the second HIFU. There are very few series out there there's actually no series out there looking at oncological outcome following a second treatment, and that's because it's so variable. The technique on how we treat patients have evolved over time, so there really is no data out there. When we look at this is Ableton data. Ableton's the device that came before the focal one by EDAP, 13 months follow-up. Essentially looking at this retrospective review, 22% of patients had a repeat HIFU. You can see that the rate of impotence go up using Ableton. People using Ableton essentially usually treat more and typically ends up being somewhat like a Hemi. So certainly more than initial Sonoblade data, which was mainly focal. Stress incontinence also went up, with the Ableton data. Then Dr. Polasek and his group at Duke looked at the Duke data and they combined it with the Cole registry. When you combine it with the Cole registry, the data is kind of all over the place sometimes because it's very tough to capture specific data points that are very important in a situation. I wanted to highlight that 53% of these patients received ADT at some point, 21% received radiation prior to cryoablation, and that's the one big limitation of the Cole registry data. But if you look at this is one of the only survival outcomes that's out there. It showed that by 10 years, 90% of patients failed, and that is probably due to selection bias due to the Cole registry. When you look at the Cole data, they were freezing prostates with PSAs of 50, and that's before the era of PSMA PET scan. So we really don't know what to make of this. What I'm trying to say is that this is poor quality data, but it's data this is the only data that we have. So we owe it to our patients to create better data. So I wanted to highlight a few cases because there's really no data in the literature pertaining to this. So this is one of our cases that it's not my patient. One of my partners treated this patient, 65-year-old man, PSA of 19, Pyrex 3 lesion, biopsy to be 60% pattern 4. Following cryoablation, his PSA dropped to 7.9. And it's 6 months PSA, you see it's going up, 11. 7 months, it's 14. We repeated that a month later because his PSA was obviously trending in the wrong direction, and that certainly was concerning. So what happened was he underwent a 6-month MRI, and we do see an area of enhancement on DCE. You can see that it's pretty close to the urethra, and he got a PET scan as well, which confirmed the same location. He was taken back for a second cryoablation. So before that, we biopsied him. It came back as 4+4 actually, grade group 4 disease. But it was low volume. He was obviously offered all of the options, surgery, radiation, or repeat ablation. Typically at NYU, we tell patients if we repeat your ablation and that doesn't work, we will most likely not do a prostatectomy on you because that will be really stuck. And in that setting, you will end up with radiation. So we give patients the option, and essentially, if they pick an ablation, we will do it again. So this gentleman underwent a second cryoablation. Following that, you can see that his PSA dropped significantly. It came down to 1, subsequently 1.3, and the MRI was good. The lesion is completely gone. Typically, when we ablate lesions that is next to the urethra, contrary to what I learned from Dr. Polasek, we do turn off the warmer at times. This is something that we've done multiple times for periurethral lesions on patients undergoing cryo. So essentially, you conduct your freeze, and what we do is we turn the warmer off, but you leave the water flowing. And as you see the rate of the speed of the water slowing down following the freeze, at some point you have to turn the warmer back on. But we do this for periurethral lesion when we're concerned that we really want to get that freeze. You don't want that warming catheter to keep the periurethral area warm enough. I'm going to briefly go through case 2. This is another case, PSA of 7.1, PIRATS 3, and MRI. He was biopsy confirmed to have grade group 2 disease on the left posterior lateral peripheral zone of the prostate. He had cryoablation done. Post-cryoablation, his PSA came down to 3.6. His MRI at 6 months looked good. This was after the point that we stopped doing 6 months biopsy. And we were, his MRI looked good. He had a new PIRATS 2 lesion on the contralateral side. So looking at this, we said, okay, we'll continue following your PSA. His PSA slowly crept up. And essentially, we got a 6 months MRI, we got a 2-year MRI, and it still showed that stable lesion that was on the right posterior lateral aspect of it. So finally, he underwent a biopsy. He was agreeable to that. We did a 4-year biopsy. He was biopsy confirmed to a grade group 2 cancer on the right side and no cancer on the post-ablation area on the left. So subsequently, subsequently what happened was we actually took him for a HIFU with the sonoblade device, and his PSA came down to 3.1 and subsequently stayed stable. And his follow-up MRI after the second ablation showed that you can see a hole in the right and left side where the lesion used to be. And we assumed he was cancer-free, but he's due for a biopsy and he is scheduled for a biopsy. We just don't have the results of that. So generally looking at our prospective registry on our cryoablation data at NYU, we've done more than 500 patients with about 46 recurrences. And I just wanted to show the audience because not all of these recurrences need to be treated. 12 of our patients are on surveillance, and then about 17 ended up with the second ablation. One of the second ablation failed, requiring him to get radiation. And in terms of whole gland therapy, 17 of them opted for whole gland therapy following the first ablation. So at the end of the day, I think that we need to treat the individual patient, not the disease. We need to have a realistic conversation about life expectancy following focal therapy. At the end of the day, most of us believe that focal therapy is to de-escalate their disease so that they are now candidates for active surveillance. So we should always determine how long they're going to live. I know we had a heated discussion yesterday at one of the sessions in terms of life expectancy and focal therapy. Most of the principles are similar to primary focal therapy, and at the end of the day, there's minimal decrease in functional outcome following the second focal therapy. Thank you.
Thank you.